I'm welcoming you all to today's discussion on CPR and life supports, basic life supports and advanced cardiac life supports, an update. First thing first, just look at the ECG tracings, monitor tracings. There are frequent premature ventricular complexes turning to fatal arrhythmia. The complexes are getting more and more frequent and turning into this is the ventricular tachycardia. Now it is coarse ventricular fibrillation turning to fine ventricular fibrillation. And ultimately it leads to an apparently flat line, but still the patient is alive. If we can take necessary action within 5 minutes, we can bring the patient back to life. And our today's discussion is all about this whole process of bringing the deadly patient back to life again. So let the heart beat again and bring the patient back to life. Welcome everybody on our today's scientific seminar on sudden cardiac arrest and life supports, CPR, basic life support and advanced cardiac life support, an update. I am Dr. Hassan Mahbubur Rahman, working as the Registrar, Department of Cardiology, Rangpur Medical College. Let's start our journey. What is sudden cardiac arrest? Sudden cardiac arrest is the sudden and unexpected cessation of cardiac activities with loss of pump function, resulting in loss of effective circulation to the brain and other vital organs. Sudden cardiac arrest and its most common consequence is the sudden cardiac death is the most common cardiac pathway for sudden death. The event is referred to sudden cardiac arrest or aborted sudden cardiac death if an intervention like defibrillation, CPR, resuscitation procedures, or spontaneous reversion restores circulation. And this is called non-fatal cardiac arrest. And the process is referred to as sudden cardiac death if an intervention like the defibrillation or other resuscitative processes or spontaneous reversion fails to restore circulation and the patient dies immediately. This is called fatal cardiac arrest. One is non-fatal, other one is fatal cardiac arrest. And the World Health Organization, it defines sudden cardiac arrest as a sudden unexpected death either within 1 hour or 1 hour of symptom development if witnessed or within 24 hours of having been observed alive and symptom free if unwitnessed. If not successfully resuscitated, individuals with sudden cardiac arrest progresses rapidly to sudden cardiac death. And the very first successful cardiac resuscitation from out of hospital cardiac arrest was reported in 1956, and he was a doctor. And the resuscitation process involved emergency thoracotomy, cardiac massage, external cardiac massage, and defibrillation. Cardiac arrest. What happens during cardiac arrest? The sudden and complete loss of all pumping activity of the heart. There is no palpable pulse. The patient loses consciousness immediately, and respiration also almost ceases immediately. It can happen out of hospital. It is called in case of an ambulant patient. It can happen in a monitor-bound, bed-bound patient. In case of hospital admission status, it is called in-hospital cardiac arrest. The American Heart Association now defines these two modalities. One is out-of-hospital cardiac arrest and the other one is in-hospital cardiac arrest. In case of an ambulant patient in out-of-hospital cardiac arrest, how to diagnose it that the patient is having cardiac arrest? Sudden collapse and fall from a standing or sitting position with loss of consciousness, blanching of the skin, unresponsiveness to shouting or shaking, absence of cardiac pulse, carotid pulse, and absence of respiratory movement of the chest no breathing, or breathing is ineffective or gasping for air. And in a monitor-bound or monitored bed-bound patient, what we call in-hospital cardiac arrest, the sudden appearance of characteristic ECG changes like the one we have seen in the first, there is a loss of BP curve, extreme failure of the patient, rapid oxygen desaturation and pulse oximetry, and a stoppage of breathing movement of the chest in a previously spontaneously breathing patient. If these two conditions are met, we can diagnose the patient as having a case of cardiac arrest. Cardiac arrest, the current estimate is, it is a leading cause of death worldwide, accounting for about 1,80,000 to 4,50,000 deaths annually in the United States. And out of hospital cardiac arrest, about 3,80,000, in hospital cardiac arrest, almost 2 lakhs in the United States. In our country, we don't have any national data. 8.5% per 1,000 admissions among medicine patients, there are in hospital cardiac arrest, and approximately 75% of cardiac arrest occur at home. That is, these are the out of hospital cardiac arrest. Now, what are the causes of cardiac arrest? Sudden cardiac death is not a single disease, but a terminal disturbance of rhythm or hemodynamics from diverse pathological processes. If we can summarize the causes of cardiac arrest or sudden cardiac death, there are some reversible causes. These are phenomenologically memorized like these 6 H's: hypoxia, hypovolemia, hypo or hyperkalemia and metabolic causes, hydrogen ion excess, hypothermia and hypoglycemia. And 4 T's: tension pneumothorax, tamponade, there is cardiac tamponade, toxic or therapeutic disturbances, or thromboembolic and mechanical obstruction. These are the reversible causes of cardiac arrest. Now, what about CPR? CPR stands for Cardiopulmonary Resuscitation. Cardiopulmonary resuscitation is the sum of total activities directed to restoration of circulation of oxygenated blood by artificial means. That means cardiopulmonary resuscitation is an artificial means for restoring spontaneous circulation. It is the only recommended action that should be undertaken without loss of time as soon as diagnosis is made. If we lose time, each minute lost decreases survival chance by 10%. It is a must develop skill. Every doctor, nurse, paramedics must know how to correctly provide CPR and actually apply it whenever the situation demands. The life support, there are 2 modalities: the basic life support, what we call BLS, and the advanced cardiac life support, in short we call it SALS. Regarding the BLS, basic life support, it is the protocol which attempts to instantly restore the circulation of oxygen blood to the vital organs. It is a set of emergency procedures used to help people experiencing life-threatening conditions until they can receive advanced cardiac care. Basic life support can be performed by trained medical professionals or bystanders who have received BLS training. The basic life support consists of prompt recognition of cardiac arrest, activation of emergency response system, immediate delivery of high quality CPR, if available, defibrillation using an automated external defibrillator, and successfully completing each of these critical actions strongly predicts the survival and recovery chance. The 2010 guideline from the American College of Cardiology and American Heart Association, they incorporated some changes in the total protocol of basic life support. The American Heart Association Emergency Cardiac Adult Chain of Survival, the links in the new SCAHA Emergency Cardiac Adult Chain of Survival are like prompt recognition of cardiac arrest, rapid activation of the emergency system, In case of our country, we have got 999, the rapid initiation of high quality CPR, early defibrillation whenever possible, and effective advanced cardiac life support. And the last one of this chain of survival, the last component is integrated post-cardiac arrest care. And this last one is very much important for protecting the neurological properties. These are the chain of survival, the latest updated chain. Once upon a time, we started ABC, the airway, breathing, then circulation. That is, look for the airway, whether it is patent, listen if there is a breathing sound or not, feel if there is any pulse. It was the very initial protocol for CPR, but nowadays it has been changed to CAB. Now no more looking, no more listening, no more feeling. What we need is our action. Chest compression first. There is no looking, no listening. Do the job first. Chest compression. So the ABC protocol of basic life support has been changed to CAB. Compression first, then airway management, then breathing. And the American Heart Association says that CPR is as easy as CAB, CAB. And the total protocol for newborn, still it is ABC, airway, breathing and chest compression, but for adult, infant and child, the protocol is chest compression, airway and breathing, CAB. ABC for newborn, CAB for others. Get chest compressions first before you worry about the airway. What is the concept for giving the chest compression? You can see here, this picture is from the Ganong's Review of Medical Physiology. We can see in inspired air, partial pressure of oxygen is about 158 to 159 millimeter of mercury, and in expired air, the pressure is about 116 millimeter of mercury. But we know that at the tissue level, the required oxygen partial pressure is about 40 millimeter of mercury. That means when the patient is expiring the air, it also contains sufficiently enough amount of oxygen that can sustain the patient even up to further 5 minutes or 2 minutes, if we can circulate this air, oxygen containing blood to the vital organs. And that is the concept why the protocol has been changed from ABC to CAB. This is called the oxygen cascade. We can see at the left kilopascal, on the right millimeter of mercury. If the patient is unresponsive, no breathing or no normal breathing, only gasping, activate the emergency system first. Call to the 999 that we need help. Send an ambulance. We need defibrillator. Then start CPR. Continue CPR. Another person check for pulse, whether there is appearance of carotid pulse or femoral pulse. If not, continue the CPR cycle. And after 2 minutes, if defibrillator is available, give one shot. If defibrillator is not available, continue CPR every 30 seconds, give 2 breathing. One breathing lasting for 1 minute. And after 2 breathing, you can take only 3 to 5 seconds, not more than this. Otherwise, your basic life support will not be effective. So, high quality CPR can save lives. So, good quality CPR is defined as a palpable carotid or femoral pulse and intermittent chest compression, chest expansion. High quality CPR. In the 2015 guideline, the American Heart Association described high quality CPR as the combined impact of 5 factors. The factors are: the CPR rate should be 100 to 120 compression per minute. The depth should be at least 2 to 2.5 inches, that is 5 to 6 centimeter in adults. Allow full chest recoil after each compression. Minimize interruption. Chest compression fraction, this is called CCF, chest compression fraction, it should be at least 60%. Best is more than 80. What is chest compression fraction? Say, if you are giving chest compression for 100 seconds, if you are continuing CPR for 100 seconds, then chest compression should comprise at least 60% of the total duration of your time. If you say that you are giving chest compression for 10 minutes, then you are continuing CPR for 10 minutes, then at least 6 minutes should occupy your chest compression. And survival chance is more if this chest compression fraction is more than 80%. This is called CCF, chest compression fraction. And ventilation. Regarding ventilation, overventilation is harmful if there is no advanced airway management, 2 breaths after 30 compressions, and in case of a patient who is getting advanced airway management, 1 breath every 6 seconds. That is 10 breaths in a minute. So, the focus for CPR is on good quality chest compression. Regarding chest compression, we have to remember some things in our mind. The chest compression allows the heart to maintain a pump function by sequential filling and emptying of its chambers. This is the anatomical basis of effective chest compression. How or why chest compression can restore blood. Positioning of CPR. Laying the patient supine on a relatively hard surface, it allows effective compression of the sternum. Delivery of CPR on a mattress or other soft material is generally less effective. The person giving compressions should be positioned high enough above the patient to achieve sufficient leverage so that he or she can use body weight to adequately compress the chest wall. Like this. Your elbow should be locked. Elbow should be locked. Use your hand like this one. This. You can interlock your fingers or grasp the wrist with right hand or right wrist with left hand and use the heel. Use the heel of the palm to compress the chest for at least 2 to 2.4 inch or 5 to 6 inch depth. These are the position where to compress.
Code BLS offers the highest.
Like this, just heeling. Keep your heel on the chest across the nipple line and midline in the half and lower third of the sternum. And compress it for a depth of at least 2.2 to 2.4 inch. Allow full recoil. Use the hip joint as the fulcrum. Elbow is locked. Total body weight will compress the chest to depress it. And the force should be applied vertically downwards. Remember one thing, very important. Your force should be vertically downwards, not sideways. Most of the time, some of the doctors or the medical students or the medical personnel push the patient like this way, from the side of the bed. When you are doing this way, when you are compressing the chest, the force slides to the paravertebral space and ultimately the heart slips. The concept is we will compress the chest below the vertebral column, above the sternum. Between these two bony structures, we will compress the heart and it will work as sequential pumping and releasing function. So everywhere we can see the elbow is locked. Look, once again, everywhere the elbow is locked. And the pumping function should allow full recoil. Just release the full force from the chest wall so that the chest wall can recoil completely. Push it harder, push it faster, decrease interruption and allow complete recoil. These are the 4 components for high quality CPR. Very important, remember it. Push it harder, faster, decrease interruption and allow full recoil. Hand positioning, place the heel of one hand on the patient's sternum and the other hand on top of the first. Fingers may be interlocked.
First,
When a person collapses, there's
Look.
still enough oxygen in their blood to keep them alive for about 10 minutes, but only if that blood gets to the brain. Chest compressions build up the pressure that keeps blood flowing to the heart and brain. If you stop pumping the chest for any reason, the patient's blood flow stops too. Continuous chest compression, CPR, keeps the oxygen-rich blood flowing.
The key is to circulate that oxygen.
The way to do that is to continuously
When you can continue this chest compression, pressure generates effective CPP, cerebral perfusion pressure is generated. Whenever you release the hand, the generated cerebral perfusion pressure drops instantaneously. And it will take another 1 to 2 minutes to develop the same cerebral perfusion pressure once again. That is why the concept is decreased interruption. Push a little harder. It was up to 2 inch, up to 2010 guideline. Now it is at least 10 inch. Push a little faster. Up to the 2010 guideline from the American Heart Association, it was at about rate up to 100 compressions per minute. But now all the latest guidelines recommend at least 100 compressions per minute. Better if we can push it up to 120 breaths per minute. An untrained bystander should perform chest compression only CPR. Look, when we are pushing harder, blood is getting to the brain. When the rate is at least 100 compression per minute, we can send the blood to the vital organs and don't interrupt. Chest compression. For how long? The entire process is repeated until a pulse returns or the patient is transferred to a definitive cardiac care. We can see the picture here. Below is the vertebral column and above is the sternum. Between these two bony structures, you have to place the heart from vertically downward. Compression and decompression. Decompression should be complete and the chest wall should be relieved from any external force. Why interruption should be minimized? Look in the left picture. The graph shows continuous compression with best possible perfusion, and whenever the compression is held, you are stopping the compression, the perfusion pressure is immediately dropped. And it will take another 1 minute or 2 minutes to gain the same perfusion pressure once again.
Cardiac arrest, the heart.
And once again here, cerebral perfusion pressure. When there is interruption, there is no cerebral perfusion pressure in between. That is why it should be ceaseless. Ceaselessly continue compressing the heart. And without any interruption, the pressure tracing is like this. The cerebrum and the other vital organs get blood continuously. Survival is related to arterial pressure generated by chest compression. And these are the different data. When to give shock, if it is possible or feasible. The 2005 guideline was harder, faster and deeper. And the latest guideline from 2010, it is even harder, even faster, even deeper. So now, the airway management. Regarding the airway management, for an unconscious patient, CPR is initiated as follows. After giving 30 chest compressions first, perform the head tilt chin lift position like this. Get your patient this way. Just one hand and another this. And it will allow the straightening of the airway. Head tilt and chin lift. This is the universal position for CPR, airway cleaning. Head tilt, chin lift position. And before giving ventilations, look in the patient's mouth for any foreign body that can block the airway. Clean and align. Position the patient supine on a hard surface. To align the airway, extend the neck gently at the atlanto-occipital joint. Lift the chin. Look, here is the aligned airway, like this. Left hand side unaligned, the tongue is falling back and the airway is blocked. And when we do the maneuver of head tilt chin lift position, the airway becomes aligned and it is opened. There is no blockage of the airway by the tongue anymore. All the same pictures. Regarding the breathing, this is the back valve mask, BMV.
The air we breathe in contains about 21% oxygen, and the air we breathe out contains about 16 to 18% oxygen. Therefore, breathing into a casualty's airway lets the rescuer supply the necessary oxygen to the casualty.
After 30 compressions, 2 breaths are given. And in case of intubated patients, 1 breath every 6 seconds. That is 10 breaths per minute. These are the position of the hand, C and E, when we apply the ambu bag or bag valve mask. We can perform the mouth-to-mouth technique for breathing. After 30 chest compressions, 2 breaths, if there is no advanced airway management. And when giving the mouth-to-mouth breathing, just whether there is elevation of the chest wall. Look it, check for elevation of the chest wall during breath delivery. Give each breath for approximately 1 second with enough force to make the patient's chest rise. Failure to observe chest rise indicates an inadequate mouth seal or airway occlusion. After giving the 2 breaths, resume the CPR cycle. Hyperventilation during CPR may contribute poor survival rates, and we have got data regarding this thing. Regarding pediatric life support, just push 2 fingers over the sternum and press it. Don't push it hard. Or hold the newborn with 2 hands, supporting its back with 2 palms and using 2 thumbnails. Using 2 thumbs to press the chest. Like this one. These are the methods for pediatric life support. Now we can go for the advanced cardiac life support. ACLS, Advanced Cardiac Life Support. Excellent cardiopulmonary resuscitation and early defibrillation for treatable arrhythmias remain the cornerstone of basic and advanced cardiac life support. Advanced cardiac life support or advanced cardiovascular life support refers to a set of clinical interventions for the urgent treatment of cardiac arrest, stroke, or other life-threatening medical emergencies, as well as the knowledge and skills to deploy those interventions. The required knowledge is also included in the ACLS skill. ACLS procedure and techniques are arranged into algorithms. These algorithms are a set of standard guidelines that improve the speed, effectiveness, and outcomes of ACLS. The goal of ACLS is to stabilize the condition of the patient, which includes restoring normal vital signs and alertness. ACLS consists of correct CPR, advanced airway management, electrical therapy, IV access, and drug therapy. This is the 05 ACLS guideline. It has been changed in 2010. The latest one is 2015 guideline. And it is also the 2010 guideline. The latest one is the start CPR immediately, give oxygen, attach monitor or defibrillator and check rhythm first, whether the rhythm is shockable or non-shockable. And one person should check for a spontaneous circulation, what we call the ROSC, return of spontaneous circulation, ROSC. If there is ROSC, circulation is returned spontaneously, send the patient to post-cardiac arrest care facility. And if there is ventricular fibrillation or ventricular tachycardia, give one shock, continue CPR, monitor CPR quality, again continue CPR for 2 minutes. And during these 2 minutes, every 30 compression, 2 breathing. Every 30 compression, 2 breathing, and continue for 2 minutes. And after 2 minutes, check for rhythm again. If there is still ventricular fibrillation or ventricular tachycardia, go for this cycle again and again, over and over again. And after 3 cycle, or after completion of 2 cycle, or giving the first defibrillation shock, we should give adrenaline, so that adrenaline will sensitize the cardiac tissue to external electrical energy and continue the cycle. And after every 2 minutes, check for rhythm and circulation. If there is ROSC, return of spontaneous circulation, send the patient to post-cardiac arrest care. And if there is no return of circulation, continue the CPR cycle. 30 compression, 2 breathing, 2 minutes. After 2 minutes, again check for rhythm, check for circulation, return of circulation. So 2 minutes, 30 compression, 2 breathing and checking. This is the protocol for ACLS. What are the phases of resuscitation? We can see it has got 3 phases: electrical phase, hemodynamic phase and metabolic phase. The electrical phase lasts for up to 5 minutes. The hemodynamic phase starts from 4 to 10 minutes, 4 minutes, and sustains for up to 10 minutes. And the metabolic phase starts when the duration of cardiac arrest is 10 or more than 10 minutes, when chance of survival is almost 0. Because we have seen that every minute lost after developing cardiac arrest, there is chance of survival reduced by 10%. So, what you have to do, you should do within 5 minutes, the first 5 minutes during the electrical phase. Whether you continue CPR, you can defibrillate the patient, do it within 5 minutes. Whenever you get a patient with cardiac arrest, you only have got 5 minutes. Remember it, only 5 minutes. And you have to buy a new life with this 5 minutes capital. So don't waste a single second even. Don't waste a single second when you are engaged in resuscitating procedure. During the resuscitative process, don't waste a single second even. Electrical phase, circulatory phase and metabolic phase, we have already said. The electrical termination of cardiac arrhythmia. These are just some hypotheses how electrical energy can restore the patient back to life. Now the DC counter shock. Defibrillation, non-synchronized random administration of shock during a cardiac cycle. Electrically terminates ventricular fibrillation, ventricular flutter, polymorphic ventricular tachycardia, pulseless ventricular tachycardia. And the cardioversion is a synchronized process. Synchronized administration of shock during the R waves or QRS complex of a cardiac cycle. Electrically terminates atrial fibrillation, atrial flutter, AVNRT, AVRT, atrial tachycardia, multifocal atrial tachycardia, ventricular tachycardia. Defibrillation and cardioversion. Both the procedure are the same. Same machine is used, same technique is applied, but when the heart is in fibrillation, the process is defibrillation. And it requires no synchronization because there is no definitive R wave or QRS complex in the ECG tracing. So, we don't have to synchronize it because there is nothing to be synchronized. Deliver the shock immediately without synchronizing. There is asynchronous or non-synchronized electrical energy delivery, and the process is called defibrillation. The heart is fibrillating, the reversion process is defibrillation. In any other conditions, when there is cardiac arrest due to ventricular tachycardia, atrial fibrillation or other causes, the process of reversion is cardioversion. And the cardioversion process should be, definitely, it should be synchronized with the R wave or the QRS complex. What happens when we apply electrical energy to the cardioversion or defibrillator? Look, this picture is from the Guyton's Physiology, 14th edition. The heart is in chaotic condition. Counterclockwise rotate the picture. The first one, the ventricle is normal, normally acting. Now, there are multiple focal points, ectopic focal point causing ventricular fibrillation. We are giving first shock. Some of the focal point is abolished. It requires second shock. Some additional focal points are abolished. And still there is ectopic focal points. We can give another shock. Then all the focal points, ectopic focal points are abolished. Now, only one point will raise, and that is the SA node. And the normal sinus rhythm will be restored. This is the physiology why in some cases more than 1, 2 or more than 3 shocks are needed. When the ectopic focal burden is high, it is very possible that more than 1 or 2 or 3 shock will be needed. Shockable rhythm, ventricular fibrillation and pulseless ventricular tachycardia, non-shockable rhythm, ventricular system, pulseless electrical activity or EMG. Now the shockable rhythms, a single biphasic defibrillation remains the cornerstone, and it is recommended treatment for ventricular fibrillation or pulseless ventricular tachycardia. Indications: ventricular fibrillation, ventricular flutter and pulseless ventricular tachycardia. Early defibrillation is essential, as with every minute of delay in defibrillation for ventricular fibrillation, the chance of survival decreases by 7 to 10%. Now, determinants of successful defibrillation. Time of defibrillation, earlier the better. Energy delivered, higher the better. Defibrillation waveform, it should be biphasic. And basically, monophasic defibrillator is now not available in this current world. Transthoracic impedance, weight body can conduct the electrical energy faster and more effectively. Shock electrode placement, this is very important. One to the right of the sternum, another at the apex. Surface area of the shock electrode and the patient's metabolic status. Biphasic waveforms appear to have an advantage over monophasic waveforms in that less energy is required for defibrillation. In the setting of ventricular fibrillation, a non-synchronized shock should be delivered, and the initial shock energy should be about 150 to 200 joules. Look, we told that the determinants for successful defibrillation. These are the pedals. These are the adult pedals. These are the contact surface. Look, surface area of shock electrodes. Sixth point, surface area of the shock electrode. This is the adult pedal. And we can change it to pediatric pedal. This is the pediatric pedal. Chest wall is smaller, shock delivery surface area is smaller. And it is inbuilt. 2-in-1. Just press it. Here's the button. Press it, slide it. Now it is adult. Both can be removed. This is the adult, this is pediatric pedal. So, sir. Okay, we have got one live person here. To keep it, these pedals are marked. This one is right marked, and this one is apex. Marking is apex. place it over here. And this one here. And shock button. Simultaneously, these two buttons should be pressed. And before, when we are giving DC shock, synchronous DC shock, here is a synchronized button. Press this synchronized button. The machine will detect when to deliver the energy. When we are getting shockable rhythm and the rhythm is non-fibrillation. In case of ventricular fibrillation, there is no need for synchronized button activation. And in that case, just charge it. Universally, right-handed paddles contain the charge button here. Just push here. The paddle will be charged. Or you can push it here. You can push it here, the yellow button. Once again, the yellow button, universal. The yellow button or the charging button. Yellow button or the charging button. You can push it here to charge the paddle or push it here to charge it. Just take it away, push here, the paddle will be charged. Now deliver the shock like this way. Or if someone keeps it here, someone push it here, you can deliver the shock from here. Two options. The orange button is the shock delivery button, universal. Each and every machine contains the same color code. Yellow button, charge delivery, red or orange button. Just charge it, push it. We'll show it in more detail. If the first shock is ineffective, give a bolus adrenaline so that the cardiac tissue becomes sensitized to external cardiac energy, external electric energy. And if available, a bolus amiodarone of 300 mg can be administered if initial shocks are unsuccessful while cardiopulmonary resuscitation is continued. Once again, don't stop CPR. Just continue CPR while the advanced cardiac life support processes are maintained. And the initial dose of amiodarone should be 15 to 30 mg per minute. 15 to 30 mg per minute. If we apply one ampoule, it contains 150 mg amiodarone. This one ampoule amiodarone should be given over 10 minutes so that we can give 15 mg per minute. If 30 mg per minute is required, just use 2 ampoule and give it over 10 minutes. We will give 30 mg per minute. Ventricular fibrillation, the most common and most easily treatable cause of sudden cardiac death. It may be due to myocardial infarction, ischemia, electrocution, structural heart disease, and electrolyte imbalance like hypokalemia. These are the ventricular fibrillation, fibrillatory wave. There is no definitive QRS complex. So, since there is no definitive QRS complex, there is no scope for synchronization. That is why the shock should be delivered, shock energy should be delivered in a non-synchronized manner. The upper one is the coarse ventricular fibrillation, the lower one is the fine ventricular fibrillation. An external cardioversion, sustained monomorphic ventricular tachycardia, atrial fibrillation, atrial flutter. We will give synchronized DC shock here. This is the ventricular tachycardia, atrial fibrillation, hemodynamically unstable, immediate cardioversion when the duration is less than 48 hours. And if atrial fibrillation duration is more than 48 hours or the duration is not known, anticoagulate for 3 weeks before cardioversion and anticoagulate for 4 weeks after cardioversion. In case of atrial flutter, hemodynamically unstable cases, low energy setting, almost 50 to 70 joule is enough. Sustained monomorphic ventricular tachycardia usually occurs as an isolated episode. Ventricular tachycardia that occurs 3 or more times within 24 hours, which needs electrical termination each time. It is called electrical storm. and it is associated with difficult to control ventricular tachycardia and is associated with increased mortality. Look, these are the modern pedals. The just chaotic movement of the heart, fibrillating heart. Place the pedals, deliver shock, and all the chaotic electrical impulses are abolished, and the SN node takes over the charge of beating the heart. These are the pedal positions in a different manner. This is the biphasic shock. Instantaneously, the shock energy direction is reversed in case of biphasic shock. These are the different positions for pedal placement or pad placement. The energy traverses the cardiac tissue and neutralizes all the chaotic activities. These are the two options. Anterior posterior position also. It is also effective. The left one is the monophasic shock or monophasic shock energy delivery, and the right one is the biphasic shock delivery. Early defibrillation impacts survival, as we have already told it. Start CPR at the 4th minute, defibrillate at the 6th minute, and CPR only or no therapy. These are the survival chances. We have already shown that chance of successful survival is reduced by 7 to 10% each minute delay. First minute survival chance 90 minutes. Initiation of CPR at 2nd minute, survival chance 80, and so on. So, if we start CPR at a duration or at a delay of 7 to 8 minutes, the total overall survival chance is only 30 or 20%. That is why the earlier the better. As soon as you can see the patient is having cardiac arrest, just jump over it and start CPR. There is very greater chance that you can bring the patient back to life. So, now let's see some pictures, some rhythms. This is the very first defibrillator machine in the world. Just one galvanometer with two metal head. Energy was fixed at the galvanometer, two metal head placed over the chest, and the second person switched on the machine. And with the passage of time, these are the evolution of the defibrillators. These are the monophasic defibrillator. Now, these are the latest biphasic defibrillators. And the biphasic defibrillators also contain self-adhesive pads for shock delivery. These are the different forms of pads. And this is the very popular defibrillator machine with cardiac monitoring. In case of a patient undergoing cardiac arrest with pacemaker placement, what are the positions for pedal placement? We have to place the pedals at least 12 centimeters away from the pacemaker generator. At least 12 centimeters away, mind it. If the patient is having any pacemaker implanted, any pedal position, either right or right, it should be at least 12 centimeters apart from the pacemaker generator. Otherwise, the pacemaker may be damaged. Pacemaker generator may be damaged. Anterior chest and anterior posterior orientation, we have already shown it. These are the different physics of the pedals. Wouldn't bother it. Monomorphic sustained ventricular tachycardia, here is polymorphic non-sustained ventricular tachycardia or torsus de pointis. These are the different waveforms. So now the shockable, non-shockable rhythms, ventricular asystole, pulseless electrical activity and sinus bradycardia. Asystole is the absence of cardiac electrical activity. There is no wave tracing in the cardiac monitor. No electrical activity of the ventricles, may be due to failure of the conducting tissue, massive ventricular damage complicating myocardial infarction. This is the ventricular asystole or standstill, pulseless electrical activity. There is electrical activity in the cardiac tracing, but there is no pulse generation. That is, the electrical activity and mechanical activity has been dissociated. We call it EMD, electromechanical dissociation. So, pulseless electrical activity or electromechanical dissociation is the clinical situation of cardiac arrest with an ECG trace compatible with cardiac output, but no effective cardiac output despite the presence of normal or near normal electrical activity. It is an organized non-perfusing rhythm. PEA, pulseless electrical activity, is an organized non-perfusing rhythm. What are the causes? Failure of the normal cardiac pumping mechanism or obstruction to cardiac filling or cardiac output. And sinus bradycardia, it is also non-shockable. The patient is in extreme bradycardia, but there is no pulse, start CPR. Don't give shock because electrical activity is there. Just there is no mechanical output of the and its manifestation as pulse. So give mechanical force only, no electrical force. Now, drugs used in ACLS, advanced cardiac life supports. The first one drug is adrenaline, then IV amiodarone, lignocaine. Once upon a time, atropine was the first drug. Sodium bicarbonate, calcium gluconate, magnesium sulfate. In very short, the first drug used in cardiac arrest is adrenaline. In case of ventricular fibrillation, ventricular tachycardia, administer adrenaline after 3 shocks. Mind it, if the patient is in ventricular fibrillation or ventricular tachycardia, use 3 shocks first. If the 3 shocks are, even the 3rd shock is ineffective, go for adrenaline push. And in case of asystole or pulseless electrical activity, first you have to give adrenaline. Persistent pulseless ventricular tachycardia, ventricular fibrillation, polymorphic ventricular tachycardia, hemodynamically stable ventricular tachycardia, white complex tachycardia of unknown origin, ventricular rate control for rapid atrial arrhythmia, amiodarone should be used as the first agent. The dose is, in case of cardiac arrest, 300 milligram in 10 minutes. So the patient will get 30 milligram per minute dose. And stable VT, 150 milligram over 10 minutes, that is 15 milligram per minute dose. And the protocol is like this. We can use lignocaine as resuscitative first agent if the patient is in cardiac arrest in the setting of myocardial ischemia, because lignocaine works best or better in ischemic myocardium. If in non-myocardial ischemic condition, lignocaine should not be the first agent. Remember it. So, you are getting a patient having myocardial infarction and has developed arrhythmia or ventricular tachycardia, ventricular fibrillation, and if you don't have adrenaline or amiodarone instantly ready for giving the pushing instantly, but you have got lignocaine, go for lignocaine. The dose is 1 to 1.5 milligram per kg first initial dose. Then after 5 to 10 minutes, you can give the second initial dose at a rate of 0.5 to 0.75 milligram per kg per minute. Atropine is no longer used routinely as the first agent in ACLS. Sodium bicarbonate with good quality CPR, acidosis develops very slowly. You can give bicarbonate only when there is more than 10 minutes has passed. Calcium gluconate can be used, magnesium sulfate can be used. So, After resuscitating the patient and getting the ROSC, return of spontaneous circulation, go for immediate post-cardiac arrest care. Return of spontaneous circulation, pulse and blood pressure, regaining, abrupt sustained increase in partial end tidal carbon dioxide pressure, spontaneous arterial pressure waves with intra-arterial monitoring, optimized ventilation and oxygenation. Oxygen saturation should be more than 94%, advanced airway management 10 to 12 breaths per minute. Do not hyperventilate. It decreases cerebral perfusion, and hyperventilating oxygen is toxic. Cerebral blood flow autoregulation is deficient in case of post-cardiac arrest care patient. That is why normal arterial pressure should be maintained. And there is hypotension management. If the SBP is less than 90, go for optimizing the blood pressure with use of vasopressors like epinephrine or dopamine. And treat the patient if he is or she is in seizure, because seizure aggravates brain injury by increasing intracranial pressure and cerebral metabolic requirements. Avoid or treat hypothermia with antipyretic or active cooling and induced hypothermia. Now it is called TTM, targeted therapeutic management, or targeted temperature management. Once it was called induced hypothermia, now the term has been changed to TTM, targeted temperature management. The temperature should be 32 to 34 degrees Celsius for initial 12 to 24 hours. In the Western world, this helmet is available for thermal management in post-cardiac arrest care patient. We can set the temperature for 24 hours up to at 32 to 34 degrees Celsius. So, post-cardiac arrest syndrome, brain injury, mitral dysfunction, systemic ischemia, reperfusion response, and persistent precipitating pathology is there. The duration of resuscitation attempt depends on the nature of the event, time since the onset, and estimated prospects for a successful outcome. Now we can go for some other aspects of CPR. If laying the CPR is required, we will get tired. That's why mechanical CPR devices are now available from the Autopulse Liveband, Lucas, Defitec, Lifeline ARM, ROSCU mechanical CPR device, and Well SCC device. It is the third generation mechanical CPR device. These are the very easiest way to continue CPR for a long time. This is the mechanical CPR Autopulse device. This is another Autopulse. This is also Autopulse device. Look. This is the Autopulse Liveband. Just put the patient in the machine and set the rate and depth. You are done. This is the Lucas gas-driven external compressor. Lucas.
I'd like to introduce you to the newest piece of equipment, S610 EMS.
This is the Defitec.
During an emergency intervention, any life-saving technique is going to require a high level of excellence in its delivery. The Lifeline arm, Defibtec's latest technological innovation, is an automated chest compression system that, as an adjunct when effective manual compressions might not be possible, consistently delivers at least 2 inches of depth compression at a rate of at least 100 compressions per minute, as advocated by AHA ERC guidelines. Built for the demanding environments of the professional first responder, its unique design and structural integrity allows for quick deployment, enhanced usability, and operation without undue deflection or distortion. Smooth and consistent, the modularized compression piston compensates for variability in chest resistance with each generated chest compression. Advanced battery technology and flexible power options allow for unmatched operating times. For victims of sudden cardiac arrest, the Lifeline Arm's precise operation ensures the high quality and continuous CPR associated with better survival. Be it on the ground, in an ambulance cot, a moving vehicle, or intra-hospital transport, the Lifeline Arm is your solution for uninterrupted CPR. Included.
So, these are the different mechanical devices for continued CPR for a long time. Now, sometimes people ask for what are the contraindications for CPR. There is a DNR note, do not resuscitate. If the patient himself or herself gives any note that in case of emergency, don't resuscitate me, or if the patient party demands that do not resuscitate my patient, CPR is contraindicated. And a relative contraindication for performing CPR is a physician justifiably believes that the intervention would be medically futile. This is an area of active research also. So do not resuscitation options that do not use SCLS may be appropriate in some cases, such as in end-stage cancer, renal disease, or chronic liver disease. What are the side effects? Only one known side effect, that is mechanical complication, fracture, refracture, fracturing, injuring the spleen or surrounding soft tissue structures. So, acquire knowledge through CME for becoming a lifesaver and expert CPR person. Education, implementation, and the CPR team. The CPR team performs CPR in a calm, quiet, confident manner with minimal interruption to the performance of BLS or defibrillation. And CPR needs team approach. The team leader controls, coordinates, organizes the team and makes treatment decisions. 4 to 6 team members are optimal. Each should know their role. And you can see during car racing, this is the pit crew model. This is the Formula 1 pit crew model. Each and every person knows their role. What he has to do. This is the pit crew. These people are called the pit crew. Each one knows their role. What to do to the Formula 1 car. And this model is applied for CPR team. The pit crew approach to CPR is a protocol for emergency responders to work together to treat a cardiac arrest victim. The approach is based on the efficiency of Formula 1 crews, where team members work in parallel to complete the task. The pit crew approach for CPR involves the specialized roles. Each team member is trained to perform a specific role, such as airway management, CPR, defibrillation, medication administration, or documentation. In-depth training. Team members receive intensive training in their roles. Well-categorized response. The team trains together to work seamlessly and communicate effectively. Assigned positions. Before arriving at the scene, each team member is assigned a position and a location at the victim's side. And discrete tasks. Team members perform their assigned tasks without a specific direction from a leader. When each member knows his or her job, no leader is needed even. The pit crew approach triangle of life. When one person is available, he will stay at the left side of the patient. When 2 persons is available, left, 1 right. When 4 persons is available, 1 left, 1 right, 1 foot and 1 head. If 6 persons is available, look here, one important thing, when 1 person is available, you can only give BLS, basic life support. Advanced cardiac life support management is not possible. Even when 2 persons is available, still then BLS is available, SCLS is not possible. When 4 persons is available, 2% will be engaged for BLS management, 2% will be engaged for ACLS management. When 6% is available, 2% is still for BLS management, 4% for ACLS management. These are the pit crew model for cardiac resuscitation approach. So learn from the experts how to give CPR effectively. And if you don't learn it, you may end up with something like this, pushing the nose and breathing on the chest. Otherwise, you can't bring the patient back to life. So work together to optimize the outcome of CPR. It's a team spirit. If everyone thinks that I am independent, I will do my job independently, separately like this one, no way, no chance of survival. So CPR action is a concerted, coordinated, orchestrated job. When this orchestrated team spirit, team function is prevailing, chance of survival is higher. And if the person forget their own job, there may be additional people to dig up the grave. So the take-home message: cardiac arrest is not hopeless. Intervention in the pre-arrest period prevent cardiac arrest. High quality BLS has biggest impact. Chest compression harder, more than 2 inch, faster, 100 to 120 beat compression per minute. Complete chest require minimum interruption. Avoid hyperventilation. Prompt defibrillation. Resuscitation drugs have not been shown to increase the rate of neurological intact survival. Ensure access to hypothermia and cardiac catheterization. Thank you.